so maybe we'll kind of get started as people trickle in, nearing 50 people now. So we're really lucky today to have Catherine Peppel come and speak to us on multimodal imaging and uveitis with a focus on OCT and OCT-A and quantitative disease detection and monitoring. We also have a panel today. We have Nupra Bakshi from Mount Sinai and St. Michael's Hospital, uveitis specialist. Myself, Panos Christakis, work through Toronto Western and Kensington Eye Institute. We have Dr. Larissa Dursko, who's the chief of uveitis at University of Toronto and works through St. Joseph's Hospital and St. Michael's Hospital, as well as Alex Kaplan, who works at Toronto Western and Kensington Eye Institute. I'd like to have Dr. Dursko introduce our speaker now, and we look forward to the talk.
Thanks, Panos. So it is my pleasure to introduce our Grand Rounds visiting professor, Dr. Catherine Peppel. I met Dr. Peppel during our last American Uveitis Society winter meeting in Park City, Utah. It seems like we were just saying ages ago, decades ago, but not too long ago. And Dr. Peppel spoke very eloquently about ocular immunology, mechanisms of homeostasis and disease. And this is a very complex topic to present in an hour, and she was very engaging for all the attendees. Dr. Peppel is an MD, PhD, and associate professor in the Department of Ophthalmology at the University of Washington. She's a clinician scientist and uveitis specialist. Her lab studies ocular immune responses in animal models with a special interest in innate immune function in the mechanism of post-infectious uveitis. Her clinical research focuses on the use of sweat source OCT-A in the diagnosis and management of patients with uveitis. Please welcome Dr. Peppel.
Thank you so much. All right, see if I can share screen elegantly here. All right, so let me give you guys this code they asked me to
monitor the audience. There's your code for your CME.
I can,
Thank you.
probably should do the Jeopardy music there. That would be fun. All right. So thank you all so much for inviting me this morning. I'm really excited to be there virtually. When I met Larissa in January of this year, and she said that this may be a possibility, I was really excited because I've always wanted to visit Toronto, particularly in the fall. So this is my little partway visit. We'll try again some other time. So the first part of my talk, I'm going to tell you a little bit about multimodal imaging and posterior uveitis. And then in the second part of my talk, I'll tell you a little bit about my work in quantitative sweat source OCT-A. I have no financial disclosures for this. So I want to think just kind of intellectually about multimodal imaging. Why use this modality, these modalities? Well, first of all, we want to document disease. I think that's pretty straightforward, but I'd like you to really think about the other things that multimodal imaging can do for you, particularly in the ability to detect pathology in ways we normally cannot. So just for fun, anybody have any idea what this fancy disease detection gadget is? So I won't make anyone unmute, but this is a Star Trek tricorder. Okay. So I like to talk about using, if I was in clinic with my trainees and I say, why are we doing an FA today? Why are we doing fundus autofluorescence? And that's because I don't have this handy gadget this way where I can just wave this wand in front of my patients and it will tell me what they have. I need to actually do the studies to detect what's going on inside their bodies. Now, other goals of multimodal imaging, besides documentation of disease or pathology detection, they're kind of aspirational goals, but are to replace some of our invasive imaging modalities with non-invasive techniques, and also to provide us better support in quantitative analysis. And we'll talk about some common imaging modalities. There are many, many imaging modalities we could speak about, ways that we can interrogate the eye other than just looking at the eye, but we don't have time for all of them. So I'm going to focus on the main ones that we utilize clinically, which are color fundus photography, angiography, fundus autofluorescence, OCT, and OCT-A. So kind of the bedrock of multimodal imaging is, of course, the color fundus image. And we basically are using this as a way to document visible disease. And it's really true that a picture is worth 1,000 words. You could spend your life basically trying to write all the descriptors that would be required to really document some chorioretinal lesion that you're seeing in your uveitis patient, or you could just take a photo. And this is going to transmit the information about the disease state, the disease activity, with really high fidelity between visits and even between examiners. Now, we started out in the field with mostly things like a 30-degree field. Things have progressed to the 55-degree field, and that was not sufficient really, so everybody started to tile together the 30-degree fields into the ETDRS7 fields, which gave us something closer to 75 or 80 degrees of the fundus. But now the real revolution has been wide field imaging, of course, that gives us a 200-degree potential view of the fundus. It's really great because these modalities are fast and non-invasive, and you can really select which field of view based on what type of pathology you're trying to capture. Now, wide field is really powerful, and I love this example because this was a patient who was a kidney transplant patient. He had a history of bilateral CMV retinitis. In his right eye, he'd had such severe disease, he had a total retinal detachment. In his left eye, we had done some laser barricade to protect him from an area of retinitis when he was active, which you can see here with this area of hyperpigmentation. So he came in with a history of some decreased vision and some floaters. And if you look in there, you can see that you can see the floaters. And I love this picture because the fellow had gone into the room without looking at the imaging prior to his exam. And the medical student who was standing out in the hallway had pulled up the images, and looking at them side by side, he actually discovered something. He didn't know what it was, but he said, hey, there's a difference between these two images. And he actually identified the retinitis recurrence. So this ability to document that this was not present before, this is something new and different, and the med student was able to put it together, I think is really highlights the power of just using color fundus imaging. A new advance in color fundus imaging as well is the using smartphones. And this has been also revolutionary in the use of this modality because it just really allows a lot more accessibility to those images. It can be done at the bedside. It can be done in remote locations. You can take these photos and share them with an expert somewhere very far away and get input that maybe you couldn't have obtained otherwise and on short notice. Now, this is an example here of one of my fellows who took a picture at an EUA for a pediatric patient. And then a few days later, we were able to get the patient into clinic. And I think you can see that really the imaging is able to document the really important features just with a smartphone image. There are problems, of course. The field of view does end up being more limited than what you can get in the clinic. There is usually some reflection artifacts, and this can be really challenging. You have to manipulate a smartphone, you have to manipulate the lenses, but there are apps that are coming along to try and help utilize this modality, and you can do 3D printed approaches to try and link the lenses or the slit lamp to the smartphone to improve image capture on the fly. But the real problem with this modality is the fact that you have to deal with all of these patient images in a HIPAA compliant, or I believe this is the Canadian equivalent of our United States HIPAA for maintaining patient data security, and you really have to be pretty tight about that. Now, when you think about using color images for quantitative analysis, it's really only done in clinical trials. And this is a laborious process. You have to send your photos to a reading center. They are masked graders that have been trained extensively to identify disease as present or absent, to determine if it's active or quiescent, to maybe even measure the extent of disease. In the clinic, though, we're rarely using this in a quantitative fashion. It's really more proxy for clinical documentation. But the real benefit of what we have from the clinic is that these are huge data sets. And if they could be utilized, they really might provide some new information about the disease. This is not, to my knowledge, really being done extensively in uveitis yet, although Doug Jabs does have the SUN2 database of images that may provide us this type of opportunity. But the way has really been led in the field of things like ROP and diabetic retinopathy. This paper came out last year. in a Nature medicine, and it's just fascinating, where they were able to use a random forest and deep convoluted network to use fundus images of patients with diabetes to predict progression in individual patients. So how powerful would this be if we could take our fundus images of patients with something like serpiginous and potentially project who is going to have a reactivation, or who could maybe go into sustained disease remission and may be able to qualify for a drug holiday. So hopefully something coming in the future. The next modality I want to speak about is dye-based angiography. So this is really an important and an essential mechanism that we use in uveitis patients, and you really have to think about what you're using it for. This is an evaluation of perfusion and of the blood-ocular barrier integrity. So it's going to detect things like changes in that blood-ocular barrier due to retinal vasculitis. So here's an active retinal vasculitis that you could potentially see just on exam, but it really highlights the presence of that vasculitis with the dye leakage there, as well as huge areas of non-perfusion. You can detect retinochoroiditis. This looks maybe a little bit bland, but you can really see the amount of leakage that's happening here on the fluorescein angiography, as well as highlighting things like macular edema, optic nerve papillitis, and neovascularization. And it is truly essential in posterior and panuveitis patients, and it can also be important in patients with intermediate uveitis. For example, if we have two patients that come in, they're both young, they're both sent for an evaluation of their snowballs, they have 20/20 vision and no CME. So what are you going to do with these patients? Well, if you get a fluorescein angiography, you may see that the patient on the left here really has only limited disease in the far periphery, whereas this patient has extensive leakage throughout the entire retina. And I would observe this patient while I would treat this patient. ICG is, of course, another excellent dye-based angiography method. And this is limited really to exploring in uveitis patients disease in the choriocapillaris and the choroid. These are images from an Optos, and these are images from a Heidelberg. And you can see once again those different fields of view, and these are normal. So what you see in the early frames are the deep choroidal vessels as well as the retinal vessels filling with the dye. And then in late frames, you just get the diffuse hypercyanescence or fluorescence in the retina, with the dark or absence of cyanescence and fluorescence at the optic nerve head and the blood vessels. So when you see disruption in later frames of that kind of diffuse fluorescence, you know you're dealing with disease pathology. There is definitely some question about whether or not this is ischemia causing this, or absence of perfusion of the dye, or if it's inflammatory blockage, but regardless, it really highlights the disease. It can be essential in some diseases and it can be adjunctive in others. And let's take a look at a few of those. So this is a patient with AMPI who shows on the color fundus imaging here, you can see the very characteristic placoid lesions of the posterior pole and maybe some very mild or indistinct lesions in the far periphery. When you perform fluorescein angiography, you can see the early blockage and the late leakage. And then on ICG, you can see that there is really more extensive disease of hypocyanescence throughout the entire posterior pole. This, I would argue, is potentially adjunctive, because if you really looked at those early frames on the FA, you can see the extent of the disease, and you don't necessarily need the ICG to determine what disease this is, but it is definitely informative about what's going on in the choroid for you. This is an fundus autofluorescence image, which is also an interesting kind of multimodal approach that you can add to AMPI patients. And you can see that there's different areas of hyper and hypo autofluorescence, and where the FAF is abnormal, it's in the areas of the dye-based leakage on fluorescein, which is really just another measure here of this is where the blood-ocular barrier has been damaged by this inflammation. So ICGA can be used, though, to detect subclinical disease, particularly in diseases like birdshot. And this is one that some people will use adjunctively, but I feel like in birdshot patients, this is almost an essential study. For example, in this patient who has pretty extensive birdshot disease, she was treated with Iluvien because she was not tolerating systemic treatment very well. And her fluorescein angiography here has shown that there's really no retinal vascular leakage, no macular leakage. She's pretty quiet. And if you look by ICG, you can see that 2 months after her Iluvien, she really has pretty quiet choroidal disease. But then 9 months after Iluvien, all of her choroidal disease has recurred. So if we were just following her with fluorescein angiography, we may continue to think that her disease was controlled, but ICG reveals that she is active. So what about the goals of replacing some of these invasive studies with multimodal imaging? So there has been some really good work that's been done in this area using OCT-A to replace dye-based angiography. It's been very successful in areas of retinal vascular disease, particularly in non-perfusion. However, it doesn't, we really have not been able to reproduce the leakage that you can see with fluorescein angiography using OCT-A-based methods. Some groups have definitely shown that you can use OCTA, both swept source and spectral domain, to see changes in the choriocapillaris. This is a patient with AMPI that shows that absence of flow that you can see on ICG. And we've also shown that you can find these hypocyanescent lesions in birdshot patients by doing OCTA of the choroid. And if you do the deeper choroidal layers in a patient with early disease, you'll find that the disease is localized where we would expect down there in the deep stroma. Quantitation of wide field fluorescein angiography, on the other hand, is really challenging. There are definitely groups that are out doing this, but it is a challenge. Many of the challenges include that the scoreable area is highly variable. Although we could get 200 degrees field, we rarely do. And so if you're going to quantitate this area, you have to define the area of quantitation first. And then most scores end up as some sort of index. So the amount of area that's either non-perfused or leaking or demonstrating neovascularization or retinal vasculitis is indexed to the total area that was scored. There's a lot of distortion in these images, so the peripheral retina is magnified unequally. Contrast varies across the eye. I think it's pretty easy to see that the nasal and temporal retina is pretty clearly viewed, while the superior and inferior has pretty low contrast. And there's lots of artifact and variation from image to image. There are efforts at doing some more quantitative analysis using this kind of grid approach that have been performed in the UK pretty much, where the areas of non-perfusion are scored in each one of these segments to develop a semi-quantitative or semi-continuous output. But this is really laborious, and if you have to get human graders involved, it's going to take a long time. So this group just recently published their approach to try and train another machine learning algorithm to identify the area of interest, to identify the areas of non-perfusion, and then to overlay this grid and determine the areas of perfused and non-perfused retina and the unscorable areas, as you can see here in gray, and to do a quantitation that would be free from human input, which has some benefits. The next step, I'd like to kind of, before we talk about OCT and fundus autofluorescence, I'd like to provide you this metaphor for looking at fundus imaging based on the stack of pancakes. So most of the time when we look into the eye, we're basically having this en face view of the retina, but we lose all of the depth information. We can have some input into the depth information by determining what color we think a lesion may be to determine its depth, but we are not necessarily for sure. The great part of an en face view, though, is that it does maintain the anatomic relationships of pathology to other structures, such as the optic nerve, the fovea, and the retinal vasculature. Now, OCT provides us the ability to turn this pancake stack on its side and really get depth information. Where is the pathology that we're interested in located? But we lose a lot of that anatomic relationship. You have to scroll back and forth, always kind of referencing the en face view to the side. What you can do though, by doing the slab analysis on OCT, you can take individual segments of the retina, once again, pull them out, look at them en face, and regain that anatomic relationship. And by pulling out specific segments, you can localize the pathology to certain layers. So the pathology in this case being the blueberries, you would find that it's maybe not here in the outer retina that looks essentially normal. It's all located down here in the choroid. As we think about OCT, there's two big concepts to consider, whether you're using either a spectral domain or a swept source system. And those two things can give you some different information. So this is the same eye that was imaged on the same day with both a spectral domain and a swept source. You can see that the retinal imaging is pretty equivalent, but that the swept source machine gives you more information about the vitreous as well as about the choroid. And it also is, they tend to be faster systems so that you're able to obtain a wider field of view. The other concept on OCT is to consider whether or not you're looking at a structural versus a flow image. And when you're using a structural image, you're getting a quasi-histologic image of ocular anatomy of the different retinal layers, the RPE, and the choroid. And all this is based on reflectance. So sometimes you may see changes in the anatomy that doesn't necessarily indicate that the anatomy is not present anymore. You may have just changed the angle of your machine or the angle of the structure to the spectral domain or swept source light source. And so you may change its reflectance. So just keep that in mind. The other consideration from an OCT system is whether or not you're looking at the flow image or the OCT-A. This, as opposed to the structural image, this is either phase, contrast, or a complex analysis of the OCT image to give you the retinal or choroidal blood flow. These images are typically looked at in segmented slabs and then viewed in the en face view to give you information about the superficial or the deep capillary plexi of the retina or the choriocapillaris. Fundus autofluorescence is, of course, another important imaging modality, and it is interrogating essentially the lipofuscin in the eye. There are lots of other autofluorescent components in the eye, and this is a really untapped resource of looking at metabolic and other functions in the eye. But when we're using it clinically, we're basically just looking at the burden of lipofuscin. Now, lipofuscin is generated as part of the interaction of the rod outer segments with the RPE. About 10 to 15% of rod outer segments per day are engulfed, phagocytosed, and degraded within the RPE. If you get complete digestion, you don't generate the lipofuscin, but there is some percentage that's always incomplete, which is why fundus autofluorescence increases over time. In older individuals, it's higher than in younger individuals. And anything that is going to impede this process of complete digestion is going to end up with increased lipofuscin and increased autofluorescence. Conversely, if the RPE is gone or if there is no generation of lipofuscin, the autofluorescence will be black or hypoautofluorescent. And so really this measure is a proxy for the RPE and outer retinal function and health. The shorthand version is if you're dealing with a change in the normal autofluorescence pattern of the fundus and you see hyperautofluorescence, you're either dealing with sick RPE or potentially degenerating photoreceptors. If you're dealing with hypoautofluorescence, then you're looking at dead RPE or blockage from something in the overlying retina. As far as the how retinal health can impact autofluorescence, just in the normal fundus autofluorescence pattern, of course, there is this area of central hypoautofluorescence that's generated by attenuation of the autofluorescence signal by the normal macular pigments. Rhodopsin can also attenuate autofluorescence, which is what explains if you've ever done this 30-degree view and then done a larger 55-degree view of the same eye, you can see that bleached pattern because the bleached rhodopsin does not attenuate the fundus autofluorescence. And so you get increased autofluorescence coming through in those areas. Retinal degeneration can also impact fundus autofluorescence pattern. And this is a patient with an autoimmune retinopathy. And what you see pretty strikingly is this abnormal pattern here in the central macula. And the question is, what's abnormal here? Is this the abnormal hyperautofluorescence, or is this abnormal hypoautofluorescence? And when you look in cross-section with the OCT, you can see that the central macula is relatively preserved, whereas the outer retina is completely degenerated beyond this point in the area of the hyperautofluorescence. So what you're seeing here is actually an unmasking of the autofluorescence, and this is a maintenance of the normal autofluorescence that now just appears hypoautofluorescent. Another thing that can impact or has been predicted to impact fundus autofluorescence, particularly in the cases of inflammatory disease, could be the presence of macrophages coming in and engulfing damaged RPE and concentrating some of this lipofuscin within their structures. So now let's look at a few diseases of the posterior pole with this multimodal imaging approach. The first we'll look at is the multiple evanescent white dot syndrome. So using OCT, you can take pictures through these kind of small white dots that are appearing throughout the fundus. And if you look at each one of these layers and you take the segmentation of either the ellipsoid slice or the outer nerve layer slice, you find different information. So these are those blueberries again. If you look at the ellipsoid layer, what you see are these kind of large spots that overlap with the areas of hypopigmentation on color imaging. In the center of these spots though, are these hyperreflective dots within the outer nuclear layer. So this is the dots on spots appearance that has been described for MUDES. When you compare those dots on spots with the fundus autofluorescence, so here we have again that en face ellipsoid layer, so those are the spots, and this is the outer nuclear layer, which gives us the dots. And you compare that to the angiography, you can see that's where you get those wreath-like hyperfluorescence on angiography, and that corresponds as well with where you can see some subtle hyperautofluorescence on the FAF image. And in this case, the idea is that what we're seeing is, once again, kind of like the retinal degeneration, is basically kind of a window through the photoreceptor there where we're not getting the normal blockage of the fundus autofluorescence signal, so it becomes hyperautofluorescent. Using, now the question may be, we've looked on ICG though, and we've seen these areas of darkness, of this hypocyanescence, and you told me that this probably indicates an absence of flow. And this was a really interesting finding by using OCT-A in the choriocapillaris slab, where people have not found evidence of absence of flow on OCT-A. Instead, what they think this is representing is blockage from that overlying, or changes in the overlying RPE and photoreceptor layer that's changing the ICG pattern, but is not actually representing a loss of flow in the choriocapillaris. So as opposed to this being something that's inflammatory in the choriocapillaris, this is now thought to be more of a photoreceptoritis, or maybe something that's in the disease of the RPE. The next disease entity, I'm going to lump together multifocal choroiditis and punctate interchoroidopathy, or PIC. There's been a lot of discussion over the past few years in uveitis societies about whether or not these are actually two different diseases, or if they're just slightly different manifestations of the same disease. And the multimodal imaging would tend to suggest that they are basically on a spectrum, and I kind of tend to agree with that as well. So I'm a lumper, not a splitter in this situation. On OCT, if you look at one of these lesions in MFC or PIC, you can see that what you get is some subretinal hyperreflective material. You get dehiscence of the RPE. You can get some outer retinal hyperreflectivity and increased choroidal transmission through the area of the lesion, probably representing disruption of the RPE. As these lesions resolve, you can see the RPE flatten back out, resolution of that sub-RPE material, and then the development of a single kind of hyper transmissible scar. And damage to the outer retina overlying that prior area of inflammation. Using multimodal imaging to interrogate these diseases, you can see a number of different patterns. So if you follow this particular spot that shows up here, you can see that it demonstrates hypoautofluorescence, and that hypoautofluorescence increases in size as the lesion resolves. Another pattern, I think maybe if you're just catching this earlier in the disease progression, where the RPE is elevated by inflammation but has not been disrupted yet, the fundus autofluorescence is actually pretty autofluorescent. But then once that rupture of the RPE occurs, then you get the hypoautofluorescence that develops and persists. You can also see multiple patterns of disease overlay with the multifocal choroiditis and PIC spectrum. The overlay spectrum with Azor has been pretty well described, but this was another interesting pattern that I've seen a few times as well, which is more of kind of a Mude's appearance overlaying active PIC. And so if you look, you can see two different patterns on the OCT. You see the same kind of choroidal inflammatory bump that we talked about earlier with subretinal hyperreflective material, increased OCT transmission, but you're also seeing, in the absence of that distinct lesion, these outer retinal changes that correspond with the areas of hyperautofluorescence. And then if you use ICG, you can see, just like with Mude's typically, much more evidence of pathology with hypocyanescence throughout all of this area where you're seeing the autofluorescence. So this kind of combined disease activity is something you may not detect just using color fundus imaging or OCT unless you're looking very closely. I think that the fundus autofluorescence in ICG really highlights this though. With the multifocal choroiditis and PIC lesions, one confounder is really trying to determine if a new lesion is inflammatory or if it's a complication, a choroidal neovascularization. There have been a number of studies that have used OCT-A to try and tease this apart. And they've broken down the lesions as to something that they would ultimately classify as inflammatory, in which they don't find a flow signal on OCT-A, versus where they do find CNVM and they find a flow signal. And more often than not, a CNVM is identified in these lesions. If you look down in the choriocapillaris lab though, what you'll often find in these lesions is the absence of flow, even in an inflamed lesion. And this absence of flow will persist after disease activity into quiescence and develop as the chronic scar. For the disease AMPI, there is a slightly different pattern. What you can see with OCT is you don't see those PEDs quite as often, but what you do see is hyperreflectivity of the outer nuclear layer and outer nuclear layer thinning, RPE irregularities, and thinning of the outer retina, including the ellipsoid layer. Sometimes you can also see subretinal fluid. This is a beautiful paper that looked very extensively at AMPI with multimodal imaging, shown here with fluorescein angiography, indocyanine green angiography. This is the choriocapillaris flow image, and this is the structural image at the same level. They use the structural image here to show that the absence of flow in these areas is not due to absence of signal. Something wasn't shadowing this area because the structural OCT was still visible, but it is a true absence of flow in the choriocapillaris. Then you can compare that with the OCT findings as well as the fundus autofluorescence. So in the area of this fluorescein leakage, hypocyanescence on ICG, you're also seeing the absence of choriocapillaris flow. The fundus autofluorescence is hypoautofluorescent here, which may be surprising when you're thinking that this is an area of activity, shouldn't there be some damage? But what really explains that is that the overlying retina here is quite edematous and is blocking the fundus autofluorescence signal in that area. As disease progresses, we get a decrease in that overlying retinal edema. You do start to unmask the hyperautofluorescence in that lesion, demonstrating the damage that this choriocapillaris non-perfusion is causing to the RPE. As the disease resolves and flow is reestablished to the choriocapillaris, you are left behind here in this patient with some permanent damage to the RPE, showing this kind of mottled hypo and hyperautofluorescence and the damage to the outer retina. And really with diseases with AMPI, I think that this demonstrates that, even though the flow lesions can resolve, you can end up with damage depending on probably the size and extent of the disease that was present in the choriocapillaris. And I think that's highlighted nicely here with this paper, where they looked at the choriocapillaris perfusion with ICG, and they showed that in these areas where there was non-perfusion of the choriocapillaris and you develop this overlying retinal edema and damage, sometimes that damage could be so extensive that it was permanent and you ended up with retinal atrophy. And in some areas where maybe the disease wasn't as profound, leading to that retinal edema, you were able to establish normal choriocapillaris flow and retain normal retina. So really AMPI, although we think about it being relatively self-limited and benign and maybe not needing treatment, we may just be lucky if this area of non-perfusion does not land under the fovea, but lands in an extrafoveal location. And I think if we tested with multifocal ERGs or other kind of sensitive ways, instead of just central visual acuity, we may find that more of these patients would benefit from treatment to prevent these permanent lesions. Serpiginous, I think, is a fascinating disease, and it has really benefited from the interrogation from multimodal imaging. Shown here is a patient with macular serpiginous that shows the typical early blockage, late leakage of fluorescein angiography, the absence of flow on ICG-A, damage to the retina. And this patient was exceedingly lucky that his fovea was just on the edge of this lesion and he maintained foveal vision despite the extensive nature of his macular lesion. The fundus autofluorescence has really been fairly revolutionary in serpiginous for identifying disease activity that maybe you wouldn't see easily on clinical fundus photographs. This patient, you can see in his acute presentation, the entire lesion was hyperautofluorescent, indicating the just extensive damage that was occurring at the level of the RPE here due to this choriocapillaris non-perfusion. He went away actually and went off of his medications, and he came back to see me at some point in time. And this was his follow-up fundus autofluorescence, which you can see had kind of modeled down to mostly hypoautofluorescence. But he had this new area of disease activity that was clearly a recurrence. Choriocapillaris imaging with both swept source and spectral domain can detect these choriocapillaris lesions. Our institution has a swept source system, so I'm showing that here. And it really very clearly delineates the area of non-perfusion in the choriocapillaris and recapitulates what you see on ICG. So this is one area where really multimodal imaging has realized its potential of replacing this invasive imaging modality. Once this quiets down, the choriocapillaris is permanently damaged, and that can be seen on these imaging modalities. We have shown too as well that when there is a recurrence, you can really detect it very sensitively with these flow deficits on choriocapillaris, and those choriocapillaris lesions actually precede what you will see with the fundus autofluorescence. We can't tell you by how much, but we do see lesions in the choriocapillaris that are larger than the area of the lesion that you will see on fundus autofluorescence. And the areas that are not showing fundus autofluorescence show the greatest ability for recovery with treatment. So in summary, I've kind of taken you through some of the multimodal imaging approaches that can localize the lesion within the retina, and shown you that we really think that MUDES is more of a superficial photoreceptor RPE type disease. The CNVM was going to be located between the retina and in the sub-RPE space, not surprisingly. That multifocal choroiditis and PIC are more of a disease of the outer retina, the RPE and the choriocapillaris. And ambiens serpiginous, really the disease seems to localize in the choriocapillaris with the overlying RPE and photoreceptors as collateral damage to that inflammation. And birdshot is located, of course, in the deeper stroma early disease. So now I'd quickly like to take you through some of the quantitative analysis in the choriocapillaris that we've been working on. And really this all kind of came out of that initial patient that I showed you that had this lesion, which we lovingly call Australia, just because of its shape. And we noticed on this patient how well the choriocapillaris lesion mimicked the ICG, and we wondered if we could take that step and perform some quantitative analysis on these images. And I had a fellow who's now faculty in Vancouver, Kayvon Paksadvezi, who went ahead and did some manual delineation of these lesions and found that if you compared what you got on traditional imaging with what we got on choriocapillaris imaging, we really recapitulated that. So we felt that this was a very reliable biomarker that we could obtain non-invasively compared to our invasive studies. But the real goal was to not do this in a manual way, but to do it in an automated way. Because, you know, with any time you're using a manual grader, you're going to induce some bias. So automation could provide us an unbiased quantitation. There's also evidence that the automated segmentation can be much more reproducible. It's not going to be subject to the variation that a human would bring to the equation. And also getting it away from the manual grading would turn it into more of a clinically viable tool versus something that was just accessible for research. And really what I had in mind was this idea of using something like what we do for OCT determination of macular edema. Because not only could you draw the boundary of the macular edema and then get this really intuitive change analysis, you automatically know things are better. But you could also get some quantitative numbers that you could do analysis with, whereas you can't do that right now with ICG angiography. So I started to work with a very talented postdoc in Ricky Wang's lab named Zhongji Chu. At the time she was a graduate student, she stayed on and is now a postdoc, and I feel really lucky to be able to continue to work with her. But what we decided to do is that we had to, first of all, be able to detect choriocapillaris flow deficits automatically, and that's where we had to start. So what we did was we took the on-phos views of both 3x3 and 6x6 sections, and then we developed a process for determining which of these black spots we were going to call flow voids or flow deficits. Then we thresholded to identify those. We excluded things that may just be artifact or below the level of detection of the system. And we also masked out the retinal vasculature so that we could have a total area to calculate quantitative metrics. And those quantitative metrics that we established were flow deficit number, mean flow deficit size, and flow deficit density. Then we decided to validate these metrics to see if they had any sort of validity in patient populations. So what we did is we enrolled 111 patients. 73 of those patients had uveitis, 28 of the patients were normal controls. We performed 3x3 and 6x6 imaging, exported the choriocapillaris lab, and identified the choriocapillaris flow deficits on each patient, and then calculated those quantitative metrics and compared them between the groups. What we found was that in control patients, compared to uveitis patients on both the 3x3 and the 6x6 scans, the mean flow deficit size as well as the flow deficit density were significantly different. Interestingly, the flow deficit number was not significantly different. But we were looking at this and we really thought, you know, this doesn't make a whole lot of sense that all uveitis patients are contributing equally to this finding. I mean, when you look at somebody with like a multifocal choroiditis and compare it to an idiopathic, you know, intermediate uveitis or an anterior uveitis patient, we really felt like you couldn't tell a difference. So we went back and looked at the data again and now separated the uveitis patients into two groups. One, group A would be patients with diseases that we would not have information that their choroid should be involved. So things like anterior uveitis and intermediate uveitis. And we also segregated out the patients into group B that had choroidal involvement. Things like the white dots that we've been talking about, sarcoid uveitis, panuveitis, and called them group B. And we compared now the flow deficit size and flow deficit density between the normal controls, the uveitis group A, which is our anterior and intermediate uveitis patients, and our group B patients, which was the choroidal involvement patients. And we found that there was no difference between group A and normal controls. All of the difference really was contributed by the group B patients. So then we decided to determine, could we just take images of patients and would they self-assort into the different groups using like this receiver operating curve? And we found that the quantitative metrics could differentiate uveitis group B patients from normal controls with high sensitivity and specificity. In fact, if you use mean flow deficit size, you have almost perfect ability to determine that someone was in this group B versus a normal control. But now the real goal, that was kind of a side project to get us to the real point, which is we want to take these images that are obtained from patients and give ourselves a boundary. So what we did now was we took this information about flow deficit size and flow deficit density and determined and used that information to threshold on a choriocapillaris image. And if something was 2 standard deviations larger or more dense than what we were seeing in a normal control, then that would binarize the image as a flow deficit lesion. Then we had an end joining function that would come along and draw a boundary around all of those thresholded lesions if they were close enough together. If they were spaced far apart, then it would segregate them into separate lesions. The output would then be a boundary that we could then overlay back on the clinical image automatically. Now, to validate whether or not we were generating anything that was truly meaningful, we had to compare the boundaries that were generated by the automated algorithm to something that would be generated by human beings. So what we did in this case was we had patients with uveitis involving the choroid. We imaged their fundus. We performed we exported the choriocapillaris slab, and then the choroidal lesion was defined on each image by 2 human graders in the algorithm. We generated 2 outputs from this, both the lesion boundary as well as the total lesion area, and we compared these outputs either using the Sorensen dice coefficient, which is a measure of spatial overlap, or we compared the area that was generated by each of these graders using the interclass correlation coefficient. Here are some examples of some outputs from our algorithm. So this was the original choriocapillaris slab, each one of the human graders and their outlining, and then what was produced by the algorithm. And total area is shown here. And I think at a first pass, you might be, pretty pleased. Maybe this worked. Well, let's take a look quantitatively. What we found is that there was actually excellent agreement on total lesion area between all of the graders. The interclass correlation coefficient was greater than 0.9 for each of them. Humans did have had the highest correlation coefficient, was very, they were very tightly correlated in the area that they identified. But the automated grader did well compared to both human graders. The pattern you can see here though, and if you look at the mean lesion area that was obtained by each of the graders, is that the algorithm actually scored the areas slightly smaller than the humans. And we think that's probably due to just where the boundary is determined for the automated grader, which is basically on the inside of any difference, and the humans tended to be slightly more inclusive and go on the outside of any boundary. The next thing that we looked at was the overlap, the spatial overlap, using the Dice-Sorensen coefficient. And all of the eyes here are ranked based on how well the human 1 versus the human 2 did. And as you can see, the overlap was pretty excellent between the humans for almost every eye. There's no hard and fast ranking system for how good a Dice coefficient needs to be in order to be satisfactory, but the general use in medicine is that anything that's greater than 0.7 is pretty darn good. And so we had satisfactory overlap for the humans in all but one eye. When we compared that to the automated grader, the overlap was satisfactory or greater than 0.7 in the majority of eyes, but I've highlighted 7 eyes that there was some disagreement between the human and the automated grader, which suggested that there may be some features that the automated grader was dealing with differently than a human grader would. So we went back and looked at some of these eyes. And what we found is that the automated grader always excluded any sort of CNVM from the lesion, whereas humans always included it. So this is basically a definitions problem. But the bigger problem was actually using the low contrast lesions. So in a lesion where maybe you might look at this and not be 100% sure where the lesion boundary was, humans tended to overestimate the lesion area, or we can't say overestimate because we don't have truth on these, but to determine that this was more abnormal than this area, whereas the computer tended to only pick the really deeply abnormal flow deficit areas. One important thing when you're going to start looking at using a boundary method or a quantitative method is how repeatable is your grader. So first we looked at taking individual images and we asked each grader to score these images 3 times, and we spaced it out by at least 24 hours between each grading session. And what you can see is that the humans do have variability. They cannot draw the same exact line every single time, whereas the automated algorithm, not surprisingly, can. So each one of the trials is shown here in a different color. If the boundaries that were drawn perfectly overlap, you get the color white. And so that's why the algorithm's images are all white. There was definitely some variation between the humans. Human grader 1 was more variable than human grader 2, which I thought was an interesting kind of personality test here. This grader tended to just draw smooth lines and encompass the lesion, whereas this grader, as you can see, was painstaking and went through and tried to actually follow the contour of the flow deficit. The variability also varied based on which lesion they were grading. So this lesion here, you can see, actually this is one at the bottom, the human grader number 2 had hardly any variation, was just meticulous, whereas human grader 1 still had a pretty high level of variation. But even, you know, our meticulous human grader 2 could be fooled in different imaging sessions about which ones he thought were flow deficits, leading to some variability. Now, the other mark of variability is if you scan that person multiple times over the same day or in different visits, how much variability do those different scans enter into the equation? And you need to know this because if something changes in a quantitative metric, you need to know how much variability is really just due to the repeat imaging. So these are images showing a patient that was scanned 4 times at the same visit, but they stepped away from the machine and came back each time. And the automated grader then provided a boundary for these lesions. Shown on top is the dice overlap, the average dice overlap for all of the images, and the coefficient of variance in the area. You can see that the automated grader does a pretty good job of redefining the same lesion every time with great dice overlap and about 5% variability at its worst on these hard to grade, poor contrast lesion boundaries. The human graders, on the other hand, had variability, again, that was more than the automated grader for the most part. And this lesion in particular, I'd like to highlight that the variability was pretty darn high with our human grader 2, who was our really meticulous one. And I think that's just because it's really hard to know with these low contrast lesions what is the lesion or not. And he had a 10% variance across these lesions imaged on the same day. We were really interested in this problem too of how come the automated grader really only selected the center of this lesion, and could we actually generate something, maybe give a human being the ability to maybe set the threshold differently for each patient. And so we changed the threshold from a really stringent threshold to a lower stringency threshold. And we were able to show that by changing that threshold standard, we were able to generate a lesion that looked more like what was graded by the humans, with better dice coefficient overlap than we had when we started. So there is some ability to adapt this automated approach And just like you can do on an OCT of the retina, where you can readjust the boundaries to improve your segmentation, we could provide that for something like this as well. So now I'd like to show you how this could be used clinically. So here's a patient with serpiginous choroiditis that was imaged at baseline, imaged 3 months later or 4 months later, and the disease was felt to be stable. And you can see that the lesion boundary looks very similar, and the total area that was measured is very similar as well. But then the patient came back and there's clearly a change in the boundary here, and that equated to an increase in the area. And that was a pretty 15% increase in lesion area. So that's beyond the coefficient of variance and would definitely highlight as a problem. This patient, also a serpiginous patient, came in and was imaged at baseline when they were inactive, had a disease flare, which you could see show up on the choriocapillaris imaging as an enlargement of the area, and then was treated, and some of the area actually did regress. So we were able to show that there was about an 18% increase in lesion area during the flare that then regressed with treatment. And this is what I was talking about, that this early, like the leading edge of some of these lesions does seem to be able to recover if treatment is instituted early enough. The part that is left behind is then the area that demonstrates that permanent change in fundus autofluorescence. This is a patient with serpiginoid choroiditis that was associated with TB, who came in with a vision of 20/80 and had a total lesion area of over 12 millimeters squared. Was treated with corticosteroids as well as anti-tuberculosis treatment, and then the lesion's area decreased and he recovered 20/20 vision. And we can see that overall there was a 50% decrease in lesion area. So we have a true quantitation of his change in disease burden over time. So in summary, what I've shown you is that we've been able to generate an automated method for choriocapillaris flow deficit, both detection and measurement. And we've come up with some quantitative variables, including flow deficit number, size, and density that you could use to track your patients over time. We've shown that uveitis patients with choroidal disease demonstrate significantly larger average flow deficit size and density than uveitis patients without choroidal disease or normal controls. We've been able to use these normative data to generate an automated method for flow deficit lesion boundary segmentation and total area measurement. And then our automated method performs similarly to a human grader, but provides excellent repeatability and can detect clinically meaningful changes in patients with posterior uveitis. And with that, I would like to acknowledge my collaborator, Dr. Wang, who is one of the founders of OCT technology, and it's a real gift to get to work with him, and very talented postdocs in his lab, both Zhangji Chu and Qingjing Zhang. As far as clinical recruitment on these projects, I've worked with a number of excellent fellows, and this has really been a fun project to get to work on. And with that, I will put our code back up again so everyone that showed up later can get their credit, and I will stop there.
Thank you so much for that. That was a great presentation, and I think we all feel that with all these new multimodal imaging modalities, just interpreting what the clinical significance of them becomes very important. I just wanted to ask you a question just regarding what you spoke about before about the use of ICGA in birdshot patients. It is a tool that we sometimes use, and I think many of us have patients that have birdshot that present at kind of a later or more burned out stage, and on IVFA don't have retinal vasculitis, but do have findings on ICGA. And I'd just like to ask you what are your indications in terms of treatment in a patient without CME, with no retinal vasculitis on IVFA, but has lesions which are demonstrated on ICGA?
Yeah. So I didn't show you some of the data that I have for a patient that came to me with fairly advanced birdshot, had clear, the very extensive fundus autofluorescence, hypoautofluorescence, like lots of scarring. Her retina was very thinned and atrophic, and her FA pretty much would stay quiet. But every time we would do an ICG, beyond the hypocyanescent spots that we would find in areas of scar, she had these more subtle hypocyanescent spots like the ones that I showed you. And we started to treat her aggressively. And when we started to treat her, she actually had some recovery of her visual field function, and she improved. And then she became allergic to her medications. She was on Humira and became allergic. So we stopped the Humira and we thought, well, maybe you'll be fine. She wasn't fine. ICG lesions came back. And so we tried a number of other immune modulators, which she didn't tolerate very well. And so we ultimately put in a Retisert. So same story, we were trying to control her choroidal disease with a Retisert implant, but she continued to have ICG recurrences. And every time she would have a big recurrence, her visual field function would decline. And so I really feel that there is importance to this choroidal disease, and you can really miss it just doing FAs. It's possible you can pick it up other ways with visual field testing, but visual field testing, as you know, is really challenging. Is it better? Is it worse? Is this just a bad day or a good day? Whereas those spots, when they pop up and when they leave on ICG, you've got a very definitive treatment effect that you can follow. So I think it's important, and I've kind of unfortunately found in patients like this, they don't tend to respond well to more intravitreal steroids. You have to treat them systemically. That's the only way to get rid of those choroidal spots. And so she unfortunately had to go back on mycophenolate, and even though it made her kind of tired and wiped out, it has taken care of her choroidal lesions and stabilized her vision. So I think that ICG is really important, and it's tough in patients like her because she's going to have many, many spots of hypocyanescence that are going to correspond with areas that are permanent scars now. But what you have to look for are new spots that are popping up in areas that when they're well controlled, they don't have those spots. And you may need to do a prednisone pulse to see if you can get rid of any spots so that you know what your treatment endpoint actually is, because the scarred spots are never going to go away. It's those more subtle spots that you can actually treat towards.
It's very helpful. Maybe we could ask some of the panelists just to pipe in terms of the use of maybe ICG-A, in terms of which types of patients you use them on. I know for me, I think obviously birdshot patients, anyone with deep kind of choroidal pathology are who I use it on. I tend to get a kind of a baseline in response to treatment, but it is a little bit harder to get here because of the cost of the dye not being covered compared to fluorescein dye. Could any of the other panelists maybe pipe in on what they do with ICG-A?
And feel free to have a different view too. Doug Jabs and Deborah Goldstein completely disagree with me on my use of ICG. They don't think it's as important. We had a knockdown drag out about this at the Uveitis Fellows Forum right before the AUS Winter Forum last year. But I'm going to convince them one day. One day I'm going to be able to convince them the importance.
I've used it mostly for birdshot patients, but not on a regular basis the way you described. So often I'll use it, periodically if it's not clear whether disease is progressing or not. But I haven't used it. It sounds like you use it do you use regularly, kind of on a yearly basis, or do you use it as required if you're suspecting a recurrence?
So for people that don't have severe disease, maybe annually or maybe not at all. If they don't have symptoms, they don't have spots that are popping up, because if these spots are untreated over time, they will progress to visible choroidal lesions. And so as long as they're not having new things pop up on color fundus, then I might not do scheduled ICG. But for some of the more advanced disease patients, people that are progressing and it doesn't really seem to make sense why, I use ICG. And I've got two patients that are very hard to treat and tend to recur very easily. They get pretty much monitoring every 3 or 4 months. They get an ICG to check and see their status.
I think that that's really interesting, and certainly it would be great if we could, we didn't have the cost issue to be able to access it more often. And I tend to rely a lot on autofluorescence to detect early recurrence, or, you know, assess the patients who seem to have symptoms that don't quite make sense when everything looks stable. Do you find that it's more sensitive than the autofluorescence then in that type of patient?
Definitely. So the interesting thing that we saw in our patients was that, you know, the deep lesions are down in Sattler's and Haller's layer. And if you let them go long enough, what they'll do is they'll just cause damage that rises up. And that rising up damage is then what changes the autofluorescence and causes those visible scars. So I think the ICG is truly earlier, you're catching it faster. Ashvini Reddy, I think, is I mean, this has been published before with ICG, that you can detect these deep choroidal lesions preclinically before they show up, you know, either on FA or on clinical exam. And I think that I just feel that the evidence is there that if you treat those lesions before they become clinically evident, you can prevent the fundus autofluorescent changes. And so I do think that the fundus autofluorescence will show up eventually, but you may be missing some disease that you could have treated earlier.
Thank you.
Interesting. We have a question from someone in the panel. Mano was wondering, in terms of the human readers, were they individuals with similar backgrounds? Were they retina specialists, like the two readers, or were they people that were just trained photographers?
So one of them was a uveitis fellow, and one of them was a ophthalmology resident. So they did not have the same levels of training. And I would be interested, this would be an interesting, fun vote. Who thinks which is which? But as it turns out, human grader 1.
My vote. Oh, okay.
Human grader 2 was the ophthalmology resident. And this is actually something, this is an anecdotal finding that I've had now in a few different areas where we've done some sort of image-based grading. And I tend to find the people with the lower level of training tend to be the ones that are more meticulous, because they're just afraid to miss something. And they will spend an inordinate amount of time and really own those images. Whereas the more expert person is like, this is the problem. This is the problem. And we've seen that actually, because I oversee the resident research projects, and I have a resident who's interested in using an AI-based approach to kind of judge plastics problems. So lid ptosis, brow ptosis, all these kind of things, to see if you could just take a picture and have an automated grader score the degree of those problems. And they had a med student, a resident, a fellow, and an attending do the grading. And they actually had, as part of the training set for the AI, and they had to throw out the attending because their grading was so poor that they just couldn't even use it. So I think that it's an interesting question, and it's an important question. I don't know necessarily how you get around that, you know, but just if you're doing these projects in the future, get med students.
Well, that's funny. We have the same experience in our resident clinic with daily anterior uveitis follow-ups. Not only do they draw the cells, but they give them names as well. So we definitely don't miss anything there. Yeah. I have one question. I think we have to wrap up soon, but one question, just kind of looking at choriocapillaris kind of thickness and volume. I know there have been a lot of efforts to try and find some kind of quantitative way of determining choroidal volume and choriocapillaris volume. I know that in a lot of my VKH patients, the number one indicator of an early recurrence is increasing choroidal thickness. And now with enhanced depth imaging and even swept source OCT, we're starting to be able to better image the choriocapillaris. Are you aware of any kind of quantitative ways of measuring choroidal volume? It seems like, I know you're doing a lot of on fast work with your swept source OCT-A, but is there any effort to try and actually quantitate volume?
Yeah, that's a great question. And I think a lot of people tried it initially when it was spectral domain, and it was challenging. Doing that posterior choroidal boundary was, you know, highly, highly variable. But yeah, you're right. With the new swept source and EDI approaches, you can get a much better boundary. You know, it's a great question. I don't know of anybody who's doing like total choroidal volume off the top of my head, but I'm sure that there is somebody. There is a group, and I actually forget his name because I'm terrible with names, but he is doing a choroidal flow index where he uses on the B-scan images that will outline the choroidal vessels as well as the stroma and come up with a flow index to see if there is an impact on choroidal flow, both in the small, mostly in the larger volume vessels, and if that changes with disease. So I would look for choroidal volume index and see if anybody is going to kind of go from that to a whole volume approach. I bet it would be his group, but I apologize, I can't remember his name off the top of my head. I can email it to you afterwards. I'll look it up.
I was going to ask one thing. Based on the study that you've completed over here, if you find activity that's kind of proven on OCT-A, has that changed what other imaging modality testing that you've ordered going forward? Like, is activity, like for a serpiginous patient that's quite clear on OCT-A, do you still get the full gamut of tests to kind of document things in different ways, or has this decreased the amount of imaging that you've ordered?
Well, so that comes down to a practical application problem. So we don't have the swept source system for me to use clinically. It's only a research application at this time. My colleague Marion Monk, who is in Switzerland, she gets everything on swept source, and she says that that has changed the amount of angiography that she does, except if she's worried about leakage. We have to kind of redirect patients of specific questions to the research imaging suite if we're going to get it done. And so I pretty much am still using all of my traditional imaging at this point.
Okay.
I
Great
wish
talk.
I could.
Yeah. Right.
All right,
Thank
well,
you.
thank you once again. Now we'll be starting the resident teaching session. So thank you again for such a great talk, and also waking up at 4 o'clock in the morning to give it to us via Zoom. And we look forward to having you back in Toronto, hopefully post-COVID at some point, to hear more about your research and work.
Thank you so much.
I feel so bad. It's still dark in your background there.
Yeah. Well, you know how it is on these northern latitudes. It's dark all the time, pretty much. So.
Thank you very much. That was great.
Thank you.